Okay, everybody, I know that if everybody could have a seat, we're going to go ahead and get started because I do have a packed agenda for everybody. So for those of you who are here in March, I'll just wait for everybody. That's fine. I can wait. So for those of you who are here in March, we were using a program called Mentimeter. We then found out that the institution actually has a license with Poll Everywhere for for specific people. So we are using Poll Everywhere. It's actually much nicer because you don't have to be connected to the internet. You can either go to the pollev.com/HRPP address, and as soon as you do that, you're in the poll and you're ready to go. Or you can go text HRPP to this number, the 22333. And I would encourage everybody to at least get in there because the bulk of today's presentation is going to be based in Poll Everywhere. So if everybody wants to take a quick second to go ahead and get into the poll, because after the announcements, most of the presentation is going to be based on question and answers, because this is a recap of what we've done in the past couple months. So again, you either go to pollev.com/HRPP, or you go to HRP or text HRPP to the number 22333. And as soon as you do that via text, it should give you a confirmation that you're inside today's poll. And then I'll give you some more explanation of how the text will work. When you're inside the website, it's pretty self-explanatory. And the first slide, everybody will continue seeing this, but if you were going to describe the series, what would you say? Educational, informational, awful, Josh is the worst, whatever it is that you want to say, and this is going to be a word cloud. So I'm going to close this because, like I said, it's a packed agenda, and those instructions will show again. They'll be shown on every slide as we go through it. So without any further ado, we'll go ahead and get into the updates for the HRPP in the past month. Forgot to pull my most recent numbers. So the first thing that I'll show, for some reason the vacancies didn't come through, but this is our org chart. This little position right here, as some of you may know, is Whaley's position. Whaley has left the HRPP. He took a position with industry. We're very happy for him. It's something that he's wanted to do for a long time. So we're fully expecting that at some point he's going to come back to UT Southwestern and be everybody's boss because he's just that amazing. But this is going to be a new position, and then we are currently looking for a part-time admin associate. So if anybody is interested in any of these positions, or knows of anybody who would be interested in these positions, please let us know. We're very interested in finding people who'd fit really well within the office. But yes, if you've heard rumors that Whaley has left, he did leave. So moving on to metrics. So like we always do, we have the last 6 months and the last 30 days. We've been very busy, but this is remaining pretty steadily. So if you go back to your previous months and look at the last 30 days, it's pretty much consistently around that 1,100 to 50 mark, somewhere in there. So our full board new studies, median turnaround in calendar days. As of 5/1, Eric's team was sitting at 69 days, but I pulled this out because this is today's numbers, and they have processed, their median days to approval is now down to 60. So it's something, we take an active look at this every week and we talk about it in the office to see how we can continue to improve it. For expedited new studies, they were at 26 days. They are now down to 16 days, processing 45 new studies in the past 30 days, which is a huge volume. So Chuck's team is doing a fantastic job. With exempt studies, the goal is 21, and we're currently sitting at 11 days, and that's pretty consistent with this sheet. And then with Reliance, we're currently, as of May 1st, we were at 32, and as of today, we're at 37. So I'll talk more on that in just a second. Moving on to eIRB Lite. So, has everybody heard of eIRB Lite, heard me mention eIRB Lite? Hands raised. It's not a poll everywhere question. So eIRB Lite is a new version of eIRB. It is going to be in the same platform. You're going to go and do the same exact process to log into the system. But what it is we've taken the smart forms and we've made them better. So for anybody who has a full board study and you've gotten an email from JODI recently asking you to confirm the number of currently active patients, the number of patients who've withdrawn in the past year, and the number of patients who completed the study, that's now just going to be a question in the smart form. It wasn't ever in there. It's information that the IRB should have as they're reviewing studies. So we've reviewed and revised all of the smart forms: the study smart form, the continuing review smart form, the modification smart form, and the reportable event smart form. For the new study smart form, that was 79 pages long. It is now about 39 pages long. So it's a lot less. Before you clap too much, there are a lot of forms that you're going to be completing outside of the system and then attaching, because regulations are changing very quickly lately. If we continue to have questions in eIRB, it means that we're inflexible and we potentially are having you answer questions that aren't accurate. And so we're moving some of the questions, for example, if you're going to be dealing with children or pregnant women or prisoners, those are going to be forms that you're going to upload into the system. So I'll get to that in just a second, but the other thing that we're going to be adding as part of eIRB Lite is the ability for research staff to submit changes back to the IRB office. So if the HRPP staff have sent you comments or stipulations, the PI does not have to issue that, nor does the delegate. That's the new functionality that we rolled out about a month and a half ago. Now anybody on the study team will be able to push that back to the IRB office. And then there's additional improvements on our side that allow us to be more flexible. So in the month of June, we're going to start training. It's going to be every Monday from 8 a.m. to 12, and then every Thursday from 1 p.m. to 5 p.m. It's going to be in BLA 224A, which is in the Bass Tower on North Campus, and the classes are now live in Taleo. So if you want to get in there and sign up, great. For anybody who does not have access to Taleo, please email myself and or Rhonda, and we will get you signed up in the system, because I know not everybody has access to Taleo. So moving on, the Reliance process at UT Southwestern. So one of the things that Rania is going to be working on pretty actively, and she's here in the audience, so if you have any questions about Reliance afterwards, please ambush her, is to improve the education and process as she gets studies at the beginning. So this is what the process should look like. And unfortunately, the process doesn't always look like this, and that's why the current time frame is 37 days, because potentially she may get the study before we've been added as a study site by the main IRB, or before potentially even the main IRB has approved the study at all. That's not what we really want and or need. So this is the process. Really, the PI should submit the intent to rely form. That's a form in REDCap that you would submit. Rania gets an automatic notification. She will go through and notify the engaged affiliates. She'll schedule a pre-Reliance meeting with the PI, the study coordinator, whoever needs to be there, and that's really so that she can help walk you through the process. If you've never done a Reliance study, those are really nice. If you have done a Reliance study and maybe you've worked with the Western IRB, but this time it's going to be Advara, their processes could be slightly different. So working with Rania, because she knows the central IRBs, will be really helpful. And is this going in the right order? Okay, so then the UT Southwestern HRPP will agree to rely, so that's not something that the PI can necessarily make a determination on. That's something that sits within our office. We would negotiate any agreements that need to be negotiated. The UT Southwestern HRPP will complete the site information sheet and local context form and send that to the reviewing IRB. That gives them local laws, state laws, anything that an IRB maybe in Maine won't have any idea about, but we do. The PI at the LEAT site would submit a modification if the study is not yet approved, or if the study is approved, or just add us as a study site at the very beginning, so that we're listed in that main IRB's application that we're going to be doing work on the study. At that point, that's when we want you to submit the study within EIRB. Up until that point, it does not need to be submitted because there's so much work that can go into these 6 steps that if we get it in the EIRB, then it's just going to sit there, and it's not going to do anything until all of this stuff is done. As soon as we get it, assuming that all the other steps are completed, we will go ahead and issue approval of that, and then the site PI would still have to get performance site approval before beginning research. So if you're doing research at Children's, you still have to go through Children's and get PSA there. I know this is a lot of information, but there's a lot of questions for the informed consent process. So poll everywhere. Just a little bit of instruction on it. So again, you can do web voting and or text voting. If you do text voting, you'll notice that all the answers are going to have a letter. So you just text A if you think that today's presentation is amazing. This is a sample, so you can let me know afterwards how amazing the presentation really was, but this is not an actual question you need to answer right now. And you would just text A, B, or C. If you realize that you maybe texted the wrong letter, you text clear, it will clear out your response, and then you can respond with the letter that you actually think is correct. If you're on the web, you don't have to worry about the letter because you just select you just select your answer, and then there'll be a clear option at the bottom if you want to change your answer. And again, any questions, you can let all of us know, but I'm going to go ahead and jump right into Poll Everywhere. So let me go to presentation mode and show you. Okay, so most of you think that it's informative. Education dispelled, misconceptions, great review, forward, interesting. So informative continues to win, and it's live, so it's changing. You will notice that over here I can lock the answers. So once we get to the actual questions, I am going to be locking them. You cannot change your answer once I show you the right answer. Okay, so moving on. Here is the first question. I just want to find out, did everybody learn something new from the Informed Consent series? And again, if you haven't necessarily got in there, here's how you get to the website, and here's how you get to the text message participation. So we're at about 30 right now. Based on previous Research Matters, there's probably 125 of you in the room.
What's your keyword for the
HRPP. And just for time's sake, I'm going to move on, because I imagine that after the questions, after I show some, there'll be some, but wait, I thought it was this. So I'm going to lock the answers and show you. So most of you agree or completely agree that you've learned something new. That's really great. Okay, so now we get to the actual question. So again, here's the question. Informed consent comes from what Belmont Report principle? And if you think that the answer is A, respect for persons and you're texting, then you text A, and that will register the answer as respect for persons or beneficence or justice or autonomy. I'm not giving you the answer by focusing on respect for persons or any of the other answers. So this is really important, and this is actually, if you happen to be selected for an AHARP site interview, because as part of AHARP applications, it is not just for the IRB, it is specifically called the Association for the Accreditation of Human Research Protection Programs. That includes all of you. You're all part of the Human Research Protection Program overall at the institution to protect human subjects. We have to submit a step 1 application, then a step 2 application. It's very similar to an IRB review, so we're going to be reviewed on what it is that we submit. And then the last step before they decide our fate is a site interview. So just like an FDA audit or an OHRP audit, they will come out to our site, and we have to give them a list of everybody who works on research at the institution, human subjects research. So they could choose any of you in this room. They could choose any of your PIs, and they can ask them pretty much anything they want when it comes to the regulations, our policies and procedures. So it's really important that you at least know where you can go to find the answer. It's very similar to any other audit of, well, I know I could talk to this person, they would give me the right answer. But the Belmont Report is really the baseline for human subjects protections in the United States. So I'm going to lock the answers. I'm going to show you what most people thought, and most people thought it was respect for persons. And guess what? Respect for persons was definitely right. So there were 3 principles in the Belmont Report. And how many people know somebody who wrote or was participated in the Belmont Report? All of you should be raising your hands because Dr. Selden was one of the primary authors on the Belmont Report. If you go to OHRP's website and search the Belmont Report, Dr. Selden was involved in that. There was respect for persons, beneficence and justice. Autonomy is actually part of respect for persons. Okay, so moving on. The agreement of parents, or guardians for a child to participate in research is called A, affirmation, B, permission, C, assent, or D, consent. So the other thing I really like about Poll Everywhere, as opposed to Mentimeter, is that Mentimeter automatically showed you those bars, and it was live. So if you were one of the late responders, like person number 50 just was, you could just say, I'm just going to wait and see what the consensus was. You don't get to do that anymore. Poll Everywhere is also a lot more expensive. So, okay, I'm going to lock the answers, and most people thought it was consent, and then the next level is assent, permission, or affirmation. And again, remember, this is the agreement of a parent or a guardian for the child to participate in research. So the correct answer is permission. The regulations define parental permission, not parental consent. Yeah. So now you could have both parental permission and parental consent. You could have, the child participating in a drug study, and depending on the disease, potentially you could have the parent also fill out quality of life questionnaires for themselves. What is my quality of life as I'm taking care of my child? And is it changing as we're going through this new drug because the new drug regimen is really, really complicated? Then that parent is also a participant, and they would have to give consent for themselves. So federal regulations require informed consent documents to be written at the 6th to 8th grade reading level. A, true, B, false. Is everybody having fun? It's a lot better than me just talking, right? That might be a biased opinion. Your opinion might be biased. Okay, so let me lock the answers. Oh, show you so true and false. That's pretty even. False. I love that I'm seeing people like, yes. Yeah. Okay, so the federal regulations specifically say that informed consent documents must be understandable to participants. And that level of understandability can vary based on the subjects that you're talking about. Now, if you also look at the research on informed consent, it doesn't matter what level we're writing the consent documents at. Generally, we're pretty much failing at the process. If you do look at how informed people actually are, we're not doing that great of a job as an industry, not just at UT Southwestern, but across the entirety of the globe. People don't really understand what they're signing consent to. But this focus on 6th to 8th grade reading level is something that you hear all the time at conferences. You hear, I was just at AHARP in April, and I heard somebody who's really, really respected say 6th to 8th grade reading level. It's nowhere in the regulations. It's actually not a bad mark to aim for. It's hard to write to that level, but You just have to make it understandable.
Is it a benchmark?
It's not a benchmark, nope. No benchmark, nope. Okay, so federal regulations define informed consent as a document. A, true, B, false. I know this is kind of a confusing question. I wrote it that way intentionally. Okay. I'm gonna cut you all off. Show you the answers, false and true. So, federal regulations define informed consent as a process. If you actually read 45 CFR 46, when it talks about informed consent under 116, and I know that now that I've said that, all of you are going to memorize those regulations exactly. It does not talk, it talks about the document for sure because it talks about the elements, but it does not necessarily say that informed consent has to be a document. So that's why when you hear people talk about informed consent, it's not just about a signature on a form, it's about the process. You know, what was that discussion like? That sort of stuff. So the next question, informed consent documents must include information that would affect a subject's willingness to participate. A, true, B, false. Okay. We get to about 50 and then we start hovering. So lock, show you what people think, true and false. It is definitely true. So this is actually something that Eric and I just corrected the convened boards on about 2 weeks ago because one of the reviews came back that this was information that was an increased risk and therefore the subjects must be reconsented. And that is definitely true, but the regulations don't actually talk about increased risks or anything and very specific like that. The regulations say that informed consent documents must include information that would affect a subject's willingness to participate. So that's why when you submit a modification to the IRB, it includes new risks. We agree with your process of reconsenting those participants. But we've also seen submissions where it's not necessarily a new risk, but it's going to be a new company. And it's potentially a new company that is drastically altering the entirety of the research protocol. And those subjects are done, but their data is going to be used in a completely different manner. The IRB could say, this is information that we think the subjects need to know, and because of that, you have to reconsent the subjects who have completed their participation. They need to know that their data is going to be used in a completely different manner than what they signed up for. That's a pretty far out example. That wouldn't happen that often, but it is not just new risks that would require reconsent. It is any new information that would affect a subject's willingness to participate. So the new regulations talk about a reasonable person standard for a lot of different things, but this is one where I would just encourage you that if you get information from your sponsors or from your PI and say, this is what I want to do as a modification, take a look at that new information and consider from your perspective, if I was a subject, would I want to know this, or do I not really need to be bothered with it? That's what the IRB is really determining. Is this information that we think the subjects should know? And some subjects may not care, but the IRB is the final say of, yes, this is new information they have to know, so therefore you have to reconsent. The UT Southwestern HRPP consent templates contain all required elements. A, true, B, false. Okay. True, false. I feel like this is a direct judgment of the HRPP office a little bit, but that's all right. It is true. Our consent templates do contain all the required elements. It was something that we discussed during January's presentation, and that's a long time ago, I know. But for the 33% false, I definitely want to address that because you will notice there are things in our consent templates that don't necessarily have to be there. For example, the witness signature or the interpreter signature. Those don't always have to be there. We do have things in our consent templates that we're going to be revising. Those are going to be launched with EIRB Lite. The reason that we tell everybody it's really best for you to use our consent templates is because if you go to anybody in our office, they could tell you if you are going to ask them about potential costs that these subjects could incur as a result of participating. They could tell you probably the exact header that element falls into and exactly where it falls in the flow of the informed consent document. If we get consent templates that are sponsor created, we have no idea where the elements are at. And so we have to verify that the elements are there and that there's no exculpatory language in their huge confidentiality and HIPAA sections. And there's a lot of exculpatory language that may come through in those sections. So it's easier if you use our templates, but it is not absolutely required. Obtaining consent should be a delegated task to appropriate staff by the PI. A, true, B, false. Okay. True. Click the correct button before I showed you the. So it is not necessarily an absolute requirement with federal regulations that you delegate the task. It's not an IRB requirement. It's a GCP requirement for sure to have a delegation of authority log for your studies, for clinical trials especially. But we can extrapolate from the federal regulations because technically every question that a subject asks has to be answered. They have to feel comfortable with that answer. And it's really hard for somebody who doesn't have the appropriate information to answer all those questions correctly. I've actually seen an informed consent process. It was not here, wasn't anywhere in the state of Texas, it was in the state of Michigan, where somebody was about 2 weeks into the job and was consenting a patient on an oncology study. And oncology studies are so easy. You know, there's not that much going on in them, so it's really easy to consent patients for it. Obviously, I'm joking. They're very complicated, very complex. The interrelationship between standard of care and research on oncology protocols is a lot of times blurred like this. It's really hard for somebody who's only 2 weeks on the job potentially to consent somebody, even if they have a ton of experience. And that person did actually have a ton of experience, but that protocol was completely brand new to her. She had no idea how to answer the questions for the subject, and it was not great because then when AHARP came through for that site and looked, they happened to choose that study, they looked at the documentation, and guess what? That was not great documentation of anything with the informed consent process. So it really should be a delegated task from the PI of these are the people who know how to do it. Research consent documents must disclose which risks? A, usual care, B, foreseeable research risks, C, alarm fatigue, D, option 1 and 2. Oh, somebody took their answer back. Then they put it back up. Okay, I'm locking all of you out. So most of you thought it was option 1 and 2. The correct answer? Only for the foreseeable research risks. So the regulations say foreseeable research risks. It's very specific. We always talk about that as the potential risk, the expected risk, or different words that really kind of convey foreseeable. But the usual care risks do not need to be in the informed consent document. The regulations are very specific that if a procedure is only being done as part of standard of care, it should not show up in the consent document. Now, you may have a usual care procedure, such as an EKG, that the study is performing more often than a standard of care protocol would dictate. For example, a patient who has heart disease may have an EKG done every 30 days, but they're getting a drug that would affect potentially their heart rate, so now they're going to have an EKG done every day because you gave them an application on their phone that can do an EKG for them, and they just have to do leads and other things like that. That is a research procedure now because you're doing it more often. The patient would not have experienced those everyday EKGs except for their participation in the research study. So those do have to be listed in there. So it's a very fine line, but it's a fine line that we, the IRB, will look at the coverage analysis. If there's any disagreement on the boards to determine what does the coverage analysis determine as who's paying for it. And then based on who's paying for it, we can extrapolate and say, these are the procedures we determine to be research, and therefore these are the risks that we have to consider. But it's very specific because the IRB has to consider the risks associated with the research. If we consider risks associated with standard of care, we would never approve any of your studies because the risk-benefit ratio potentially would be too high. We only want to look at the risks associated with research. Jane, you have a question. More of a statement, okay.
What about all the labels we have to put in for blood draws, and infection, and MRIs, and noise? Just our option 2.
So if you are doing blood draws as part of your study, and they're all standard of care, they really shouldn't be going into the consent form. Something that we're working on with the EIRB Lite launch of new consent templates. Yeah, we only want research procedures listed in there. Federal regulations require that the consent document be signed by the subject and by the person obtaining consent. A, true, B, false. You guys are taking a long time to answer this one. Is everybody nervous? I can't see who submitted anything. It's all anonymous. So true, 45, and 7 false. The federal regulations only require that the person obtaining consent sign never. And I know that I said that in a very confusing manner. Let me say it again. They only require that the subject sign, both OHRP and FDA. OHRP actually only requires that the subject sign the document, nothing else. FDA requires that the subject sign and date the document, nothing else. It isn't until you start getting down to IRB and institution-specific policies around the country that you start seeing anything about the person obtaining consent. Now, GCP may have requirements in there, but the U.S. federal regulations only talk to the subject signing the document. And they don't require the date necessarily unless it's an FDA-regulated study. They don't require the time. And so if you ever leave here, which none of you ever will, and go to another institution where there's a different IRB, you may see completely different requirements. For example, my old IRB used to require that the PI sign the consent document within 7 days of the subject and the person obtaining informed consent sign the document. And as you can imagine, for any of you who have busy PIs, it was just non-compliance all around. Pretty much nobody was able to comply with that requirement consistently because if a PI is on vacation for 10 days and you consent a subject on day one of their vacation, that was non-compliance because our form specifically said 7 days. So you may see some interesting requirements, but really the federal regulations only require that the subject sign. Our policy and procedure requires subject and the person obtaining informed consent, date and time. And the time is really so that we can confirm that research procedures did not start before informed consent was obtained. Consent must be documented via consent note per regulations. A, true, B, false. One more. Okay, I'm going to lock you out. False and true. This is kind of a trick question because technically both answers can be considered correct. The HRPP policy does require a consent note. Let's just start there. Per the HRPP policy, you do have to write a consent note for every patient that you consent. And technically, it's true. So OHRP and FDA both require that informed consent be appropriately documented. And that's really what they leave it at. They say that informed consent must be appropriately documented. And they then go on to talk about the signatures. So if you only look at the regulations, you could interpret that a signature from the subject on the form is appropriate documentation, except when OHRP goes and FDA goes to sites and does audits, a signature on a form is not appropriate documentation. So OHRP and FDA have put out guidance that really say that a consent note needs to be written to document what was discussed, that all questions were answered. Who was in the room? You know, if we're talking about a patient who wasn't able to consent for themselves, was it both mom and dad? Was it just mom because dad is unreasonably available? All that stuff needs to be documented. But the regulations don't technically say it, but because of the way they've interpreted it for their own audits, it's a required thing that you have to do if they actually come out. Consent must be reobtained with every consent form change. A, true, B, false. And I know we have a lot more questions, so I'm going to go a little bit quicker. False and true. It is definitely false. If you change a period on a consent form, you do not have to reconsent every subject. You must obtain reconsent if the IRB tells you to. So if it's in EIRB that you said no, and then it's in the letter that we said, no, you have to, you have to. We're the final arbiters of that. But also, if you have any new information that would affect their willingness to participate, you have to get reconsent. Participants must receive the original consent document and HIPAA authorization. A, true, B, false. So the key word was must, because it is definitely false. They do not have to get the original, and you should always keep the original. They should get a copy. The regulations say that they should get a copy. Minimal risk screening procedures can be conducted by participants before consent is obtained. A, true, B, false. So most of you thought it was false. Some of you thought it was true. is false. Now, for minimal risk screening procedures, the IRB could waive documentation of informed consent, but that would still mean that informed consent has to be obtained verbally before you can do those minimal risk screening procedures. UT Southwestern IRB does not allow or approve use of electronic consent. A, true, B, false. This got added because I keep getting lots of questions about e-consent, and I want to dispel the rumors. So, dispelling the rumors. Yes, we will approve electronic consent processes. If you go to our policy manual, it is in there. There's actually a section under informed consent, e-consent. And you're probably asking, okay, what do I have to do? You have to get informed consent via the electronic process. That's about what it boils down to. You have to have a signature, you have to have documentation. It's all the same things that you have to do on paper. You're just using a program to do it. Can I store the original electronically? Yes. What if you're doing a registry or repository study and you have thousands of consent forms and you want to scan the original and save them and get rid of the paper? Great, do that. E-consent is fantastic. And I can talk about this because he gave a presentation at Children's last year. Kason Hicks, he's probably going to get a lot of phone calls and emails now, and he's going to hate me for it, but he's using a program called Freevo. You could also use DocuSign. You can also use RedCap. There's a lot of different ways you can do e-consent at this institution. Please use it. This moves into the next question. The UT Southwestern IRB does not allow or approve consents with multimedia. So for example, a consent process where you start them off with a video, and then you move to the paper or electronic written word, or you have pictures in the middle of it, whatever it is, multiple ways of presenting the information. A, true, B, false. Okay, so I don't have to dispel too many rumors here or misconceptions. We will approve consent forms with all the multimedia that you want to use. In fact, you'll potentially see stipulations where we will say, this is a really confusing thing. And if you have a picture, it's suddenly less confusing. Take the picture from the protocol and put it inside the informed consent document because we think that will help subjects understand what it is that you're talking about a little bit better. If you're using a video to start the informed consent process out, we just have to be able to see the script from the video. We're completely fine with that. And anything that you can do to improve the subject's understanding of the research trial that you're talking about, great, do it. Federal regulations consider blank to be the first step in the consent process. A, screening, B, enrollment, C, recruitment, D, chart review. I almost caught myself saying there's no wrong answers. There are wrong answers. So, pretty split. Recruitment is considered to be the first step of informed consent. So that is why the IRB has to review and approve all recruitment documents. Because if a subject sees a flyer and then is really interested in participating, you've started to give them information about the protocol and about the study that makes them want to get more information about it. So the regulations have considered recruitment to be that first step. A person with a physical handicap preventing them from signing must have an LAR signed for them, and an LAR is a legally authorized representative. A, true, B, false. And I thought about writing this one a different way to say a person with a physical handicap is considered to be a person with cognitive impairments, because we get that all the time in EIRB, where that will be listed under the cognitive impairment section that persons may not be able to sign because they're physically handicapped. That is not a cognitive impairment, so they don't need to be listed there. And they do not need to have an LAR sign for them. If they have a physical handicap, you can get verbal consent, and if you go to our policy and procedure manual, we have requirements for when a witness may need to be in the room to document that verbal consent because somebody has a physical handicap. So I would recommend that if you encounter that, you go read that because we approved it, so you have to follow our policies. Then the kind of corollary, we always get these questions together, physical handicaps and illiterate subjects. An illiterate participant can sign for him or herself, A, true, or B, false. Somebody in the office pointed out to me that this question doesn't make a whole lot of sense because if they're illiterate and they're not willing to sign, then technically can they sign for themselves? I didn't have time to change it, so maybe they can consent for themselves. I don't have any responses yet. Can you all see the question? And you've responded? Okay. That's weird. So true, false, and it is true. Again, if they can make any mark that they want. Kind of going back to Old West movies where people just make an X or they make a very specific squiggle, whatever it is that they want to do. You could even say potentially that my signature looks like an illiterate subject because it's literally just a squiggle that never looks the same. But people can make their mark. If they're not willing to make their mark and they just want to give you a verbal consent and authorization, then again, it just goes back to look at our policy procedure manual for when a witness may need to be in the room. The informed consent document is the only consent-related information an IRB needs. A, true, B, false. Yeah, I know, this one's a thinker. I'm seeing a lot of faces out there like, what exactly is Josh talking about here? It was written very specifically. I rewrote this one like 20 times. So most of you got it right. It is false, because we need to know, how are you first approaching the patients? Are you doing it in a private manner? Are you doing it in a manner that will protect their confidentiality? What does their recruitment process look like? How are you going to continually or assess whether or not they really understood the information? In EIRB Lite, you'll see there's a new form that goes into much more detail about what the consent process should look like, and there's questions in there that you're going to have to answer because it's an IRB form that will, I think, prompt you to think a little bit more fully about the consent process than just you're obtaining it or you're not obtaining it. Who must sign both the consent document and the short form document? So this goes to non-English speaking subjects. A, subject, B, person obtaining consent, C, PI, D, witness. Good job to the 54% of you who got a witness. They must sign both the consent document and the short form if you're using the short form. If you're using the short form, the subject should only sign the short form, and the person obtaining consent should only sign the consent document that is in their language. And the PI, good job for everybody for not choosing PI, because PI is not required to sign anything unless they're the person obtaining informed consent. What methods are acceptable to submit a translated document to the HRPP for approval? A, certification of translation, B, verification of translation, and C, congressional approval. I wanted a third answer, so I put a third answer up there. Hopefully none of you choose that. So this is one where you could select both. Should have showed a checkbox instead of a circle. Did it show a checkbox? Okay, that's my fault then. I apologize. I tested it and it showed me a checkbox on my iPhone, but maybe I changed it. But it is both certification of translation and verification of translation form. So those are forms that we have, or the certification would come from any service that would provide a certification for you. We have on our, I think we have it on our website now. The last time I mentioned it was on the website. We did not have it on the website. It should be up there now. If it's not, we're redesigning our whole website, so give us a little bit and shoot us an email requesting it. But we do accept a verification of translation, which requires somebody who has appropriate training and expertise to do it, and then the PI to validate that that person has appropriate expertise and training. And you also see more information to come about translations coming through the HRPP office for your documents. That will launch with EIRB Lite. Probably talk about that in June. When using a fully translated consent document, the interpreter must sign the consents. A true, B false. False. So when you have a fully translated consent document, the person obtaining informed consent signs on the English summary or the English document. The subject signs on the fully translated version, and the interpreter is in the room. That's all that's required. The interpreter does not need to sign. There is a interpreter signature line on the consent templates that is going away. When using a short form, the witness may be present remotely for the discussion. A true, B false. True. So the regulations, when they talk about a witness, when it comes to a short form, the witness must be present for the oral conversation. It literally says the word oral. You do not have to be in the room if you're the witness. There may be institutional policies that would prevent that from happening, but if that were the case, you could never use language line, because they're only there for the oral conversation. They're not actually in the room with you. So they do not have to be in the room per the federal regulations for human subjects research. You are consenting a parent and a 12-year-old. The child shrugs his shoulders while playing on his phone. Enroll the child into the study. A, definitely. B, probably not. Fantastic. Yeah, definitely. They did not give assent. A subject enrolled by her LAR regains decision-making capacity during study participation. The subject must be reconsented. A true, B false. True. Yes. Now, so they regained capacity during study participation. They were, something was happening to that subject. They must be reconsented because they regained decision-making capacity. 2 parent signatures are required if the IRB determines that the study presents minimal risk, more than minimal risk with the prospect of benefit, more than minimal risk without the prospect of benefit, or never. Yes, it is only more than minimal risk without the prospect of direct benefit. When it is approved in this manner and you don't have two parental signatures on your consent form, we will add the extra consent or that signature line and not necessarily make it a stipulation. We'll just add it and approve your documents. Here's the version that you should be using. A 9-year-old is active, coming to UT Southwestern for research treatment on a study until he turns 24 years old. You must obtain written assent at age 10, written consent at age 18. C both, D never. So this is an institutional decision. It is not written in the federal regulations. And we have decided that we only require written consent at age 18. If you go to another institution, both may be required. My old institution with a children's hospital, that was our policy. It was 12 to 17, not 10 to 17. But if a child turned 12, you had to get written assent from that child. And then you had to get written consent if they stayed active while when they turned 18. But at UT Southwestern and its affiliates for which we approve studies, you only have to obtain written consent at age 18. Yes, question?
So if a kiddo enrolls at like 9,
Yeah.
and there's like some disability or whatever, and they can't, sign on their own or anything, and they turn 18, do you have to reconsent the parent?
So the question was, if a child is 9 while on a study and they have some sort of disability that would prevent them from being able to give assent, even if they were 10, do you have to reconsent the parent when the child turns 18? And no, you would not have to. Now, well, let me go back. Technically, you would if the parent becomes the LAR and they're still active on the study. But if you're talking about like a registry or repository study where you're just keeping the data for long term and they're not active, then that's why I specifically said coming to UT Southwestern for research treatment. They do not have to give re-consent if they're not active. But I originally said the wrong thing. If the child turns 18, the parent as the LAR would have to give permission, but not necessarily consent. Yeah. That was confusing. I'm sorry. So you can submit any questions you want, or you can yell them out at me and I'll repeat them for the camera. And it can be about informed consent, EIRB light. Yes, Jean.
Josh, you mentioned the EIRB light classes and there's lots of opportunities.
Yeah.
Is it just one 4-hour class or is there a sequence or classes?
Yes, so the EIRB training, it is 1 4-hour class. It is not, you don't have to come to all of them. Definitely not. It is 1 4-hour class. Okay, I'm not seeing any other hands. I'm not seeing anything in poll everywhere. Thank you so much, everybody. Come back in June. Have a great day. Have a great Memorial Day.